It's important to know the vocabulary before we move forward with this video. So we want to know that filtrate is something that is filtered out of the body, or in other words, it's going to become the urine. And then we have something called that we reabsorb through the kidneys. When we reabsorb something, well, also known as reabsorption, we're bringing it back into the body. Okay, we have two different kinds of arteries that we're going to be dealing with. Afferent arteries are the ones that bring the blood into the glomerulus. Your glomerulus will determine the GFR, or the glomerulus filtration rate. When your glomerulus filtration rate is less than 60, you can say the patient has chronic kidney disease of at least stage 3. So that's not a good thing. Okay, your efferent arteriole is the artery that will take the blood away from the glomerulus back into the body. So E stands for exit, and it will take it back into the body. Anything that's get filtered through the glomerulus and enters the nephron is now going to become a filtrate, and it's going to become the urine, and it's going to be passed out of the body. Anything that is reabsorbed is going to go back into the body. So we can start with proximal convoluted tubule. Here's when you'll have reabsorption of sodium, chlorine, potassium, magnesium, calcium. You would even have glucose and bicarbonate being reabsorbed here. When I say reabsorbed, it's going back into the body. So you have a certain class of medication, also known as SGLT2 inhibitors, used in diabetes patients. So you prevent this reabsorption of glucose back into the body, which means the glucose will stay into the filtrate in the proximal convoluted tubule. So your SGLT2 inhibitors work here. Another thing that is important to note is that you're reabsorbing bicarbonate. Bicarbonate is basic in nature, so it will increase your pH. But if you block the reabsorption of bicarbonate, then you're going to decrease the pH and make it more acidic. And people might even have metabolic acidosis if they have chronic kidney disease, because they might not have enough reabsorption through the proximal convoluted tubule. Another thing that happens is as the filtrate is moving through the nephron, it's now going to go through the descending, which is going down, loop of Henle. Here's where you're going to have the reabsorption of water. And as the filtrate is moving through the loop and going up the ascending loop, here's where your sodium, potassium, calcium is going to be reabsorbed, but not water, because water was already reabsorbed in the ascending loop of Henle. So here's where your loop diuretics is going to work in the ascending loop of Henle. So you'll see here that because all your ions were reabsorbed here, you're going to deplete that, because when you prevent the reabsorption, you're saying you're going to stay into the filtrate and you're going to get out through the urine. So you can also notice that calcium is one of the ions that was being reabsorbed. Now that you're inhibiting that, calcium is also going to stay into the filtrate and going to be passed out through the urine. And because of that reason, loop diuretics will decrease your calcium, also known as calcium depletion, and people might have bone mineral density loss. Okay, the only time water will be reabsorbed in the loop is if there is a presence of ADH, the antidiuretic hormone, also known as vasopressin. And this will only happen if your blood pressure is low. Your body wants to increase the blood pressure. So when you release the ADH, you will reabsorb water, reabsorb sodium, and you will increase the water and sodium retention. And because of that, as a result, you are going to increase the blood pressure. But in the absence of ADH, you're not going to reabsorb water. You're only going to reabsorb all the ions, and loop diuretics is going to block it, and it's going to make sure that the water and the ions stay into the filtrate and get out through the urine. Then as the filtrate moves through the distal convoluted tubule, here you'll have your thiazides working. So the thiazides will also block the reabsorption of the ions. The cool thing about thiazides is that it doesn't really block the calcium reabsorption because it works in the distal convoluted tubule. So patients who you're concerned about the calcium depletion, you can give them thiazide. So this is a good thing compared to the loop diuretics. And then when you move down to the